Emergency room visits are among the most difficult, vulnerable times in our lives. In today's challenging economic environment, emergency rooms are among the most difficult, challenging places for hospitals and doctors as well. Emergent Medical Associates can help you change that.
The administration wants to be able to be proud of the quality of care that is being delivered day in and day out. They need a strong group of clinicians with a good academic background who are personable, who understand patients in need and patients in pain, who show compassion, who demonstrate teamwork. And the end result for the hospital is an enhancement of its reputation and as well greater ER volumes, a greater number of admissions, and an increased standing within the community.
Now, I could have gotten involved with a lot of different organizations. I got involved with EMA because they do three things as well or better than any group I know. Reduce liability while increasing reimbursement and increasing patient satisfaction and result. The process begins at EMA's offices in Manhattan Beach, California, where a large team of professionals studies the hospital's unique needs.
Healthcare is an intrinsically local business, and we understand that. And an understanding of the local needs really demands a unique solution for each hospital. And that's what we do. We go in, perform a needs analysis, do incredibly thorough front-end work.
That includes demographic maps, EMS surveys, questionnaires, and meetings with administration and staff.
We interview the entire medical staff, nursing, lab, and x-ray, and the board of supervisors to find out what it is they want from an emergency department. We take particular note of the things that they would like to see performed better in the emergency department, and we use that as our action items.
The first action item, staffing.
We make sure that we have adequate staffing of physicians 24 hours a day to make sure that we're always overstaffed.
Making an ER efficient requires a special breed of physician who is clinically excellent and customer service oriented.
We've been very fortunate and very favored in having developed connections to the major residency programs. We typically get the chief resident and best graduating from each and every class.
The reason I stayed at EMA is because my colleagues that work with me all take medicine very seriously.
Two unique programs then provide motivation for ongoing commitment.
We have a proprietary web scheduling program that we use because the needs of scheduling physicians in an ER are unique.
The fee-for-service model empowers the physician by reimbursing him based on the quality of his medical care and the experience at the bedside. When physicians feel that they earn more, if they're more efficient and document well, they feel that they are the owners of their own practice.
With the group format, you have actually a motivation to see more patients. The patient's benefit seems to be that they're seen much faster, the doctors are more invested in their care.
That investment pays off in quality of care, improved patient flow, and overall efficiency.
We look to make sure that our lab and x-ray turnaround times are meeting best-in-breed measurements based on American Hospital Association guidelines.
Satisfying the medical staff is also paramount. One of the functions of the ER is to be an outpatient office for the doctor, to reduce the pressure on private doctors, to make it easier for those doctors to have their patients' critical care problems taken care of, and to get the full referrals and information they need for follow-up. So we make the doctor's life easier while we make the patient's life better. EMA recognizes that does not just depend on the doctors.
The patient experience is actually set, we believe, in the first few minutes of the visit. Emergent Medical Associates actually works with the registration staff, the triage staff, educating them, and in some cases, scripting how we approach the patient and their problem.
The results are clear and reproducible.
We make sure that our wall times are perfect in under 2 minutes 90% of the time. Our patient satisfaction scores are notably better than many other facilities. By means of example, in one of our emergency departments, we had the greatest turnaround in satisfaction in that company's history.
The approach pays dividends with nurses as well.
Since EMA took over, I've noticed that there's been a definite increase in efficiencies. We've made an effort to increase our census very effectively, and there's a big emphasis on patient care.
EMA extends that to paramedics. We teach everyone to get up and greet paramedics, take the history personally, make restocking easy so they can get in and out fast, encourage them to come back for follow-up. We hold monthly paramedic tape reviews and other events so they know they're part of our family.
In every case where we've embarked upon this program, we feel the results have been dramatic. There is a group of patients that the paramedics do have some discretion as to where they will come, and we've seen results with a 50% improvement and in some cases up to 100% or a doubling of paramedic traffic.
While shortened wall time, patient satisfaction, and an increase in visits increase revenue, profit also depends on reducing liability. EMA takes 4 steps to accomplish that: documentation, risk management, ongoing education, and peer review. The first step, documentation.
A well-documented chart that covers all aspects of the patient care leads to higher reimbursements by improving the level of charge. There's a secondary effect to that because in improved documentation, we're creating a better chart to diminish our medical legal risk.
The effect across the organization has actually been phenomenal. We have reduced our claims to premium ratio and the frequency of a professional liability event with our physicians well below the national average.
The second step, risk management.
So we put on a risk management summit that all of our doctors attend on an annual basis to make sure that they are getting the most cutting-edge training and most up-to-date casework that they can possibly be receiving.
14 elements. We looked at what it is that risk is. Essentially, risk is everything that you do in emergency medicine, from the time that we hire an individual physician to the point that he's in the emergency department treating that patient.
The third step, ongoing education with written and video case review. The educational programs draw very unique physicians to EMA, like Tina Wu, who took EMA's one-of-a-kind fellowship.
There are 3 different components, the first being the academic, which included getting a master's in medical management, and then there was a clinical component, working at various hospitals within EMA, and actual administrative component where I worked in the office and also on-site in the hospital. I wanted to do clinical work, but I also wanted more than that. I wanted to prolong my career, potentially, and learning the business side of medicine, and I thought the perfect place to do it was EMA.
The fourth step in risk management, peer review.
We do peer review once every 2 months at a minimum.
These 4 components are the cornerstones for EMA's Emergency Department of Excellence. They've been dubbed the EMA effect by EMA's clients. The results speak for themselves.
EMA does an outstanding job to bring in top-notch physicians into the organization. What that does is limits our liability on the outcomes of our patient care.
That extends to overall hospital quality as well, where EMA is a leader in Joint Commission preparation and presentation.
Our group has never had a single citation or deficiency according to JCAHO, and it's a record that we're very proud of.
Another reason to be proud, EMA's community marketing and outreach program, where many members of the staff go out to the community and find out what their needs are and help them cope. I'm just one of the people who participates. Whatever the needs are in that community, earthquake, fire preparedness, concern about bird flu, what was called the swine flu, I go out, I talk about it, I interact with them, I answer their questions, so they feel connected to the hospital and to EMA. So they're more likely to come here more often, more likely to use the hospital, and much more likely to be satisfied with the experience. And while the whole group stays connected to the community, Dr. Edwards, who is a former president of Cal ASEP, stays connected to the governing bodies that regulate care, liability, and reimbursement.
We've developed a 2-way dialogue of both them understanding the problems that we face to deliver quality care, and I have learned in turn what their future plans are for upcoming legislation, and being able to talk to them and have that 2-way dialogue allows us to improve the quality and planning for the future of our group and our patients that we serve.
The future and the present. What you get with EMA is a carefully planned transition and startup that improves all aspects of ED efficiency. a group dedicated to the best interests of the patients, medical staff, and administration. An ER that never closes and is there for the community. A partner in helping improve your hospital, reducing liability, and increasing revenue.
I think we were one of the first groups in the country to actually prove a return on investment in the emergency department.
I think they've realised that patients are key, that we have to satisfy our patients. They have a choice.
We never take our eye off the fact that we're the most noble of professions. And when hospitals succeed, we succeed.
If you have a group that really cares about you from the front door until the time you leave, you're more likely to be satisfied, you're more likely to get better faster. And that's what EMA does.